So I'm in academic medicine. And in academic medicine, it means you occupy sort of different roles. So I see patients, but it's actually not the most of what I do. So 25% of my time is seeing patients who are admitted to the hospital with different complications of their cancer therapy or their cancer treatment. And so I do see patients with different diagnoses. It can be breast cancer, it can be lung, it can be GI cancers. That's what I do clinically. I mean, that's 25%-ish of my time. The majority of my time is research.
Mhm.
And so my research funding has been mostly focused on global projects. So my global project, which I have spent most of my research building, is in Botswana. And Botswana, because Penn, so where I work now, has a long-standing relationship with Botswana that started with the HIV epidemic and research and clinical infrastructure that was built around that. And now there's a desire, sort of policy-wise and from a research perspective, to expand that into cancer care. And so a lot of my research has built on that infrastructure. And so I do research in Botswana, and that means having a research team that's based in Botswana, but I also travel to Botswana. My travel was a bit sporadic initially, or not sporadic, but just wasn't as coordinated. I now have a 5-year-old, so we travel in the summer. I get to do research, and I also get to mentor medical students and trainees, so either fellows or residents who are interested in global research. So I do that as well. And then in the US, I do some health disparities work. So there are a lot of similarities when you think about health equity and disparities, right? I feel like in the way, like the domestic disparities that we see is somehow amplified in the global setting. But a lot
Hmm.
of the strategies that we think about that work in these settings are similar. Like think about community healthcare workers and their role in potentially being a bridge between patients and the healthcare system. These are systems that work so well in different parts of Africa, and Botswana was used for HIV care and Rwanda. And I'm thinking about how to bring that to the US when I think about our low income populations. And so, in a way, there's been an organic transition to think about, domestic disparities and how some of my research work in the global space can inform that and sort of vice versa. So, majority of my time is research, and then I do a lot of mentorship. I mentor anyone, but, I feel very passionate about mentoring underrepresented minorities because I think the way in which we create sustainable change is by really creating a new generation of workforce that is sensitive to health equity, but also training providers and researchers who represent diverse communities in the US.